this is the second time that we've had Russell. And just to remind folk, Russell's a professor and director of research at the North East London Foundation Trust, has an interest in and practices mindfulness as a trainer and as a relational psychiatrist, which is what he focused on a lot last time, and deeply involved in this open dialogue project, which hopefully we'll learn a lot more about tonight, and is a presidential candidate. Is that right? If people could keep themselves muted during the time that Russell's talking, that would just enhance the quality of the recording, I think. And we can go from there. Russell, yes, I mean, if you want to use your screen to share.
Yeah, sure. Okay, I'll put some slides up. Tell me if you can see them. Then I'll put it on a slideshow. You see these?
Yes.
Yeah, okay, I'll put it on, start the slideshow going. Right. So yeah, so thanks for inviting me back. Lovely to see you all again. And yeah, as you heard, obviously I've been a consultant psychiatrist for nearly 20 years now, and also part-time academic. I've worked across the system, inpatient, crisis, PICU for a few years now. I'm in a community recovery team in North East London, and director of research in my trust, associate medical director, part-time academic. I've also been very active in the Royal College, so I was a nationally directly elected member to College Council for a number of years, and then I've sat on a number of executives, the academic faculty exec, the London regional exec, and general adult faculty exec. And what I've been doing is I've become particularly interested in the trajectory of psychiatry over the last, well, over the century, really. And it's been an interesting story, really, if you're sort of piecing little bits together. And we kind of start back about 100 years ago with this text from Jaspers. And in that text, this is almost one of the sort of origin texts of psychiatry. In that text, they talk quite explicitly about the importance of the dialogical dimension of psychiatry, the importance of dialogue, relationship, and how important that is in terms of unearthing psychopathology and maintaining relationships with people, allowing a recovery process to ensue. That was a significant part of his writing. Historically, psychiatry has always been seen this way, right, with two pillars, with a technical pillar, which in the last 50, 60 years, I'm going to go back, last 50, 60 years has been about pharmacology, and a relational pillar, which is about those bonds that we form with patients and that dynamic and what difference that makes to outcomes. And in the previous time I spoke to you, you'll recall there's a lot of evidence around this. I'll recap some of that shortly, but that context within which we do our work, the way that we relate to patients itself makes a significant difference to the outcomes that people have. Now, in terms of how this has changed over the years, my thesis is that the relational arm, so we go back here, the relational pillar has very much withered over recent years. And in terms of understanding the origin of that destruction, if you like, the King's Fund did a really interesting piece of work earlier. And what they did is they looked at the process of deinstitutionalization, how the asylums were closed. And they went back and they examined government documents, transcripts of meetings and minutes, and then they wrote a really good paper about what actually happened behind the scenes. Now, the Secretary of State at the time was Keith Joseph, and what they discovered is that part of the rationale for closing down asylums, obviously there was a wide consensus for it, everybody agrees that's the right thing to do, but they also found this an opportunity to save some money. So what they did, every time an asylum was closed, about 20% of staffing costs was also cut in each regional health authority when they closed asylums. And so what they did with that is that people were saying that when we close asylums, we should maintain the staffing levels in order to maintain their long-term relationships we're able to have with patients, which is what was happening in the asylums. And they didn't do that. And so our ability to do that relational work reduced significantly at that point. However, it wasn't that bad. There was still significant resource in the system enabling us to, work on that relational dimension fairly well. However, services continued to slide since then in terms of resource in mental health. And just recently, there's been an acceleration of that. So between 2010 and 2015, about £3 billion was taken out of mental health services in the UK in that 5-year period. Often through various saving schemes called SIP savings, etc. It's done in a very sort of almost secret way So on the one hand, the government in the UK have been talking about parity of esteem, but on the other hand, actually, mental health services are being bled by various schemes like SIP savings to take money out of them. And of course, on top of that, not only has the resource reduced, but the bureaucracy has increased. So the amount of time we can spend with patients has reduced. And as I mentioned last time, we're now in a situation where actually it can easily take longer to record an assessment than to actually do it. You know, the amount of different fields we have to input things onto electronic patient records has been growing over time, so that slowly there's more and more time required to actually record patient contact than to have the contact itself. Nursing time routinely is spent more than half the time on computers, and then additional requirements just keep getting added on. And there's a really interesting study around this that was published just this year, in which basically they found that whenever electronic patient records have been introduced into healthcare systems, the burnout amongst clinicians increased. And there's a very strong correlation with that. Now, why is that the case? And it certainly can't be because typing is harder than writing on a piece of paper. It's almost certainly because electronic patient records are open to abuse, because what can then happen is that the system can then start to load things on top of there, like extra fields you have to complete, extra boxes you have to tick, and before you know it, you're doing a lot more stuff than you would have done. Whereas in patient records, none of that was the case. All you had to do was just keep writing on the next page. But in an electronic system, there's a lot more possibility to get clinicians to do more and more. And that's the reason why almost certainly this is correlated with burnout. So on top of that bureaucratic element, over the years, our system has evolved in a way that's basically led us to have multiple different teams that patients have to travel through. So it's become a bit of a conveyor belt. So, for example, in the large parts of the country, you have like a primary care team, then a single point of access team, a triage team, a brief intervention team, and a longer recovery team. And when I worked in a PICU, patients would have had 5 or 6 consultants before they came to me. I did a report for the Royal College when I was in the General Adult Faculty Executive around models of care. We surveyed over 100 colleagues across the country, and we asked them what they thought was was the biggest issues facing their work at the moment in the model of care they worked in. And the strongest consensus was around lack of continuity of care. Colleagues really felt really very much regretted and lamented the fact that they didn't have good continuity of care. They had to keep saying goodbye to the patients, when they're in crisis or inpatient, and see them again. That breakage in continuity of care was a real issue. When we asked people, what can make a difference, they had some very creative ideas in terms of maybe some of the staff moving between the teams, following the patient between the teams, having primary consultants across the care pathways. So there are different ways of doing it when we put continuity and relationship back into the central focus. And the virtue of doing it, the value of doing it, is really essentially evidenced by some fantastic studies. One of the biggest studies was done by Rosemary McCabe and Stefan Pree back in 2008, and they looked at therapeutic relationships across a range of psychiatric settings. They looked at inpatient, outpatient. They looked at secure wards, rehab, community. And across all of those settings, they found that actually there's a strong correlation between therapeutic relationships and patients' outcomes, and wherever you sit in the system. So, one can predict the other. A load of studies then happened as a result of that into therapeutic relationships in psychiatric settings. And Sweeney then did a bit of a literature review a couple of years ago in 2018, and they found there's a really strong body of evidence to show that therapeutic alliance, therapeutic relationships really improves outcomes, creates positive outcomes. There's good evidence around that, but as I say, that the relational pillar has been withering nevertheless during this time. And this is a slide that I nicked from Gwen Adshed, who gave a wonderful talk in the college plenary, in the college congress. And she showed how in slide B, when we're purely listening to somebody, when we're spending the time to just purely listen to someone, different parts of our brain are active than if we're listening and also thinking about what to say next. So thinking about what we've got to then record in the notes, symptom fishing, things like that. It's a very different thing that we're doing, and it's experienced very differently by the patients as well. This is something I've been interested in for many years. So one of the first studies I did around this is when we measured clinicians' mindfulness scores. So this wasn't about how often you meditate, or even if you know what mindfulness is, it measured mindfulness as a trait, in terms of how much people were able to be present in the moment and in even various activities, whether it's in the gardening or cycling or something, just see how capable they are on the mindfulness side. And then we compared that to the therapeutic relationships they had with their patients. We found a really strong correlation. The higher the mindfulness score was, the better the therapeutic relationships they have with their patients. That's almost certainly because when you look at any description of therapeutic relationships, it very much talks about how actually those therapeutic relationships are very much about the ability to be present, to follow patients from one moment to the next, rather than using a pre-planned map about it. So what I then did, and I started running mindfulness retreats for psychiatrists. Started this many years ago. I had to pause because of the pandemic. I've got another one coming up end of the year. And what I looked at the colleagues who are coming on a particular retreat in 2015. It's a sort of 3-day retreat. I run a sort of typical pattern of a 3-day retreat with a period of silence in the middle of that. And we looked at their burnout scores before and after. We looked at their therapeutic relationships before and after, and also their mindfulness scores. And the most unsurprising result was, of course, after the retreat, their mindfulness scores improved. So that's the objective. So that wasn't particularly surprising, but it's good to know we were actually managing to do that. The other thing we noticed is that actually we monitored over time, their therapeutic relationships improved as a result of the retreat and the regular mindfulness they were able to practice afterwards. And also their burnout levels had also reduced. And that correlates to my own experience with mindfulness as well. So that was an interesting finding. So people have been increasingly talking about working in an integrative way, which is putting that therapeutic relationship at the center of care and how important that is. And it is about, reintegrating that relational and therapeutic arm with the technical pharmacology arm and being able to, eke both into their jobs. And doing that means that we can engage more easily with the social determinants of care, what's brought them into the system in the first place. We can understand what's important to them in terms of the spiritual and cultural aspects of their lives and what a difference that makes too. And it will result in services that are, as a result, more trauma-informed, because we're creating safe spaces then in which people can actually start to bring out some of what's led them to us in the first place. Now, how do we start to move things then as a result? What can we do that starts to make an impact on all of this? Well, the first thing I think we need to do is to be really explicit about the state we're in. I mean, mental illness equates to 23% of the disease burden in the UK, yet we only get less than 8% of the NHS budget. So that clearly can't be right. We need to be very clear about that. We need to be very clear about the fact that 3 billion was taken out of the mental health system between 2010 and 2015. And even though there's a recent investment in community mental health in England, that has not in any way made up for the much larger amount that was taken out of it. And what we also got to be clear about is that new funding for new things is not what we need, right? We don't need to improve quantity. Often when you get new funding, it's to open new teams or set up new services or meet new targets. What we really need actually is new funding for the existing services so that we can build capacity within them and do what we do now, although with more time and attention to patients. So we need to be clear about what our ask is. And we need to use the research around therapeutic relationships and all of this to really argue that case. We need to argue about the culture of our roles, about having that relational and technical dimension back again, and how that, we need to be able to be masters of both again and have the time to do both. And we also need what I describe a bonfire of bureaucracy. We really need to have a scrutiny, and there needs to be a campaign at a national level in which we talk about scrutinizing all of the inputs that clinicians need to make and determining whether or not each of them is essential to patient care. And if not, it needs to go. So then we can shrink that administrative burden significantly. It's only possible if it happens at a national level, if there's a national campaign against it that can then filter down. It's very hard to do it sort of freelancing on your own in a particular area or region, even in a trust or a health board. So the other thing we need to think about is new models of care that really focus on that relational aspect, that really enable us to develop continuity of care. Open dialogue is one such approach. As was mentioned at the beginning, I've been pretty central to trying to trial that in the UK. So essentially what it involves is teaching staff in aspects of family therapy and systemic ways of working, so they become experts also, as well as being doctors, nurses, social workers, OTs, as well as being psychiatrists and having their own expertise, they also become experts in working with families and networks. So finding the patient's resources around them and actually working with them in a way that helps to create a safe space where recovery can occur through those network meetings. So we forge these network meetings. We train staff to actually coordinate these meetings and really learn to therapeutically engage on that basis. As Gwen Atchett said in her wonderful talk in the College Congress that I mentioned, she said, our words are our surgical tools. And it's very much about teaching clinicians about the use of our words and how we can maximize those therapeutic relationships and also maximize the relationship people have with each other and really use that as a sort of therapeutic healing tool. Continuity of care is fundamental. You can't do this by working in a sort of stop-start way and saying, okay, now you can go to another team and then another team. It has to be the same clinicians involved in setting up those network meetings that become like the backbone of care throughout the care pathway. So whenever we trialed it, it wasn't just about training clinicians, it was also about getting agreement with the operational directors and trusts to enable us to actually have a consistent care pathway so that people can have these network meetings that follow them throughout the whole care pathway where a lot of the main decisions are made. No, we were very lucky. We applied to the NIHR back in 2016 to get a grant, and in total we've got just under £3 million of grant from the NIHR. The chief investigator is Steve Pilling, who's he's also the mental health lead on NICE guidance. I actually went to him in the first place about 10 years ago to say that I'm going to run a trial one day into Open Dialogue, and I hope that I can bring the evidence back to him for NICE. And halfway through the conversation, he got so interested in it. He said, "Listen, do you mind me being involved in the trial? How would you feel?" I said, "Of course, that'd be fantastic, make a huge difference." And because he was involved, we were able to get a whole panel of academics involved from universities across the country, and then eventually get our grant. We launched our first teams in 2017 across 6 different trusts. We then had to pause because of the pandemic, because no one was able to recruit to non-COVID trials during that time. Lots of our teams they're relatively small, so they risked being decimated by the reprovision that happened. So staff had to fill in gaps in other acute parts of the service, like going to inpatient, being redeployed into inpatient services, etc. So at the end of the lockdown, when we were able to restart recruitment, we then asked the team, "Look, do you want to carry it on? What do you want to do?" And they all unanimously said they really want to carry on. They want to finish off the trial. They really believe in this way of working, which was a harbinger to one finding, which we've already declared. So the teams reassembled. We then continued to recruit, and we finished recruiting about just over a year ago in autumn last year. And that's 500 patients recruited to the study altogether, which is a very large study, mental health trial, the largest model of care mental health trial in the world at the moment. It's a cluster randomized trial, which means that the geographies where we recruited from were randomized. So we developed clusters of GP surgeries. We drew them out, so rough, sort of similar in terms of morbidity and referral rates. And then half of them were randomized to Open Dialogue, half of them were randomized to treatment as usual. So it's a cluster randomized that way, so that a patient is automatically in one arm or the other, even before they're referred into the service. As soon as they're referred into the service, if they have a crisis level of need, they need to see high-level services, then they get either Open Dialogue or treatment as usual, depending on what their address was, basically, or who their GP was. What we're looking to do is to, we finished the recruitment towards the end of last year. We've got 2 years of follow-up, so about halfway through our 2-year follow-up period. And we're going to look at a number of things. The biggest thing is time to relapse. Does Open Dialogue lead to people relapsing less over 2 years? Do they last longer before they end up bouncing back into services? And also, do they get hospitalized less? And then we'll look at other general recovery outcomes and functional outcomes, symptom outcomes as well as looking at potential mediating factors like social network size, agency, how much influence do they have over decision making, and that kind of thing. Does that seem to mediate the outcomes that we're having? Now, there's very unusually for a trial like this, we can already declare some outcomes. One of them, which is we had to sort of declare really at the early stage. Another one which surprised us, but the extent of it surprised us, which is why we can start announcing it. The first thing is that in 2017, when we launched our pilot teams, we had to demonstrate whether or not Open Dialogue was deliverable, could be implemented within the NHS. And so we ran it for 1 year in 2 pilot teams, and we were able to show in both of them, yes, actually, we can implement full-scale open dialogue. We have some adherence measures. We're able to scrutinize them and judge them to be actual open dialogue happening within the NHS. So we demonstrated that it's doable. The second thing, though, we found is that successively across all of the teams, the retention rates in the open dialogue services are much higher than in the treatment as usual services. So in the open dialogue teams, we're seeing a lot higher staff retention. So if I talk about my own service, on the open dialogue side, we've had about 20% turnover since 2017. So about 20% of staff have left. Even that 20% that left only left because it's a small team. So when they needed to go up to band 7 or a higher band, a higher, sort of rank to get promoted, they weren't able to do that within the team because it's a small team, so they had to leave the team. And that's why we had about 20% attrition. On the treatment as usual side, we've had 100% turnover since 2017, because everybody in the team now is new and was not a member of the team back in 2017. So there's been 100% turnover in this time, whereas in open dialogue is 20%. There's a 5 times difference in the turnover rate, in the retention rate. And that's been consistently the case in every single trial site across all 6 pilot teams. So that was so stark that Steve basically and I had a discussion. We said, well, we can start to put this into our slides when we're talking about the trial now, because clearly that will be an outcome of the trial that we'll find. And obviously, the other outcomes I mentioned are yet to be finally determined, but we have a couple of hints in terms of which way that's going. One is that we did have some focus groups of the early pilot sites. The 2 first pilot teams that launched were my own team and one team in Kent. And we found the patient experience in the open dialogue services was a lot more positive. These aren't quantitative outcomes, but they're qualitative. Their reports of their experience of having the service and what difference it made to them was a lot more strong and very clear compared to the treatment as usual group. So there was a real difference between the 2 groups. The other thing is that one of the trial sites, one of the first pilot sites, was in Kent, and they had actually been running an open dialogue service for a couple of years before they entered the trial. So they were the first service to do this. And so they published a paper on the patients who'd experienced open dialogue before the trial started. And what they described is that this innovative approach, it provided continuity of care within the social network, improved carer support, and significant improvements in clinical outcomes and patient experience had been noted as well. So they actually found some pretty solid results. So in both, there's sort of a little trail towards the main study, if you like, that gives us a bit of info on where things are going. But in all honesty, the broader trial that would give you a fundamental, most significant result is unknown to us, right? I don't know anything about the control groups and what the data is. So we'll see. We're going to collect the final evidence towards the end of next year and likely publish in late 2024, early 2025. So, overall, what I'm saying to bring it all together really is that, in order to really improve our services, to bring relationships back into the heart of care, we need more investment to increase capacity in our services. We need the reinstatement of our original roles, a real description that we work both technically and relationally in the way we work. We need a real attack on drive against bureaucracy. We need more joined up models of care. Open dialogue is only one of many examples of that. And we need to argue for all these things by coming together with many professional groups like the RCN, the British Psychological Society, British Association of Social Workers, and bringing all of them together to do this. And it's fundamentally, and I talk about a commission for compassionate care that we can bring together. And some of the scandals that we've seen recently, Panorama and dispatches about some of the things that have been happening, very shocking treatment that we've seen people receive. Some of these things can give us an impetus to this, right? Set up a commission in response to that, in which we start to describe explicitly what's needed really to improve the care of our patients in terms of bureaucracy, models of care, capacity, etc. You all know, some of you are aware of my relational psychiatry blog, which I've helped, people can subscribe to. If you're not already subscribed, by all means, put your details in the chat. I'll subscribe to. It's a 20-minute video that I do once every month, just to talk about the evidence around therapeutic relationships and what difference they make to outcomes. And we invite some colleagues who are doing the research and others to that when people are interested. I'm still running the retreats for psychiatrists. I'm restarting my first one after a significant gap due to the pandemic. It's towards mid-December, 14th to the 16th of December. We still have some spaces. I've been expanding the number of spaces. It's based at Cambridge University. They've been very, very good host in that every time I ask them to expand the number of places they have, I've expanded it up to 100 places now because we booked all the original 70. Yeah, so we still have some space. It's mindfulpsych.uk is where you can go to book yourself into a 3-day retreat with other psychiatrists from across the 4 nations. Yeah, this is my email address, obviously. I'll stop sharing there. Yeah, open it up to any conversation.
Brilliant. Thank you, Russell. That's such a lot to think about there. And I'm sure people will want to comment or ask questions. I've got a few ones which I could throw in there. Ian, do you want to pitch in?
Thanks, Russell. I'm quite preoccupied just now because I've been working for the Scottish Government 2 days a week. It will end in a week or two.
Okay.
On the issue of how psychiatry deals with co-occurring substance misuse and mental health patients. And Scotland, we've just had a Mental Welfare Commission report, fairly strongly worded, saying ending the exclusion was its title. And the perception was that general psychiatry, and this kind of came out of Dundee, where I think the culture maybe wasn't great, was excluding people who coincidentally were drug addicted or alcohol addicted, and denying them access at times of crisis when they were suicidally depressed and so on. So I suppose my question is, what you've just described to us, is it involving that 30 to 50% of patients in general psychiatric clinics who may have comorbid alcohol and drug problems? And is it a way of working with multi-morbidity, comorbidity? I'm kind of interested in that. Obviously, I've got my own views having done this project, but the real world of general psychiatry is having to deal with drugs on the wards, behavioral problems that are, patients who undermine their recovery with alcohol and drugs, cannabis, etc. So, I mean, it's partly I'm asking you as a presidential candidate, but also in relation to what you've just presented.
Yeah, sure. So a number of the services that were involved in the trial, as part of their general service intake, certainly haven't excluded people who were substance misuse. So in my own service, for example, I know patients for whom that was fundamental, right? So the significant alcohol problems as well as the depression that we were treating, and we treated them with open dialogue. And yes, so very much we've got a large experience of that across the trial. The trial criteria themselves were sort of specific, so it didn't take on everyone that our services saw. But in terms of the services, we all have experience of that. And yeah, I mean, we found that it was very helpful to be able to bring people together around the patient and all of their network. We actually found very interestingly that when we had to go online during the pandemic and start doing meetings online, it improved things because we were able to then bring family from around the world, right? So suddenly what was impossible because you're all in the local area became possible just by doing it on Zoom. And that systemic way of treating made a huge difference because they could all tell their story, and they all have, often in this kind of situation, everyone has a very different story, right? And there's no consensus that everyone thinks this happened. You might have the service user who has their own experience, which involves a lot of grievance potentially against family members, but then the family members have their experience, which involves the opposite, right? And the thing about the skill of open dialogue that we train clinicians is not to create consensus, right? We don't go out of our way to try and get everyone to agree with each other. We're actually trying to facilitate a meeting where everyone's different voice is heard. We call it polyphony, trying to bring out polyphony. And this seemed to be really conducive to supporting a recovery process within an addiction framework, where people are all able to say their piece, their very different piece, because they've all been wounded, and often by each other in very different ways. And that was the beginning of a bit of a healing journey for them, in which, in the end, then the people who, felt aggrieved and family members who felt estranged were able to come and support that person again because they were able to say their piece. And we were able to create a bit of a structure and support around the person to help with recovery. Now, didn't, of course, mean that we cured everybody overnight kind of thing. And like with all of these situations, there's 2 steps forward and 1 step back. But we saw some great stuff, and we've seen in fact, I got an email from a patient who was talking to, just dropped me a line, who we discharged about 18 months or so ago, talking about how her life has transformed, and alcohol was a big part of herself and her family, and how she says specifically because of Open Dialogue, it helped bring her family together, it helped enable her to overcome her addiction and get out of services. So yeah, we've seen some good stuff happen for this. It's not a panacea, it's obviously going to be difficult, but it enables us to grapple with the difficulties by learning some of these skills working systemically, which is really good to see. So yeah, a number of colleagues in different pilot sites are reporting those kind of experiences in this sort of comorbidity that you describe. Yeah.
Thanks. It sounds like you're inclusive and not excluding people with comorbid addiction. Yeah, which is
in the services.
Needed. It's what's needed, really.
Yeah.
Thanks. Chris, you've got your hand up too.
Thanks very much, Russell. I'm wondering just perhaps for people who might be watching this video, would you be able to just go into a little bit more detail about open dialogue in terms of maybe the principles and how it actually works in practice, kind of beyond the idea of having this social network?
Yeah, I can put up a couple of slides about it if you want. That might help. Yeah, because I sometimes give a formal presentation specifically in Open Dialogue. So let me just do that actually. I gave a presentation to College Council about Open Dialogue recently. That's sometimes a good one to get the sort of basics described. So what I'll do is I'll just share these slides. Let's have a look. Right, so share the screen. There we go. Okay, right. So hopefully you should be able to see that now. And I'm just gonna, can you see those slides? Yeah, and I'll put it on slideshow. Yeah, okay. So I'll skip through some of this. So I'll start with a little bit of history of Open Dialogue. So it was actually invented by two psychiatrists, so Jukka Aaltonen and Birgitta Alakare in northern Finland. They had some of the worst outcomes in the world, actually, over there, which is what led them to do this. They were so bad that they were able to kind of halt their services and restart a series of experiments, one of which was Open Dialogue. And what they did is they trained all of their staff in family therapy and related ways of working, so that the response everybody got involved that systemic approach as well. Every crisis was an opportunity to kind of rebuild a network around the patient. And the network was seen as competent or potentially competent partners in the recovery process from day one. So the emphasis was on building good therapeutic relationships, but also building good connections between the network themselves. People sometimes ask, can you do Open Dialogue with an individual? Yes, you can. You can still think systemically with them about who influences your life, what's led to the current situation, who else has had an impact on your situation. And then we have peer workers in all the teams who can help to create a bit of a network over time around somebody as well. Or we can do things like in the sessions, if your mother was here today, what would she be saying? So we're thinking systemically the whole time, even if it's with an individual. They had some pretty phenomenal outcomes when they started doing this in northern Finland. They found that for acute psychosis, after 2 years, 74% of their patients returned to work or study after 2 years, and after 5 years, 86%, which was a massively low relapse rate, right? It's the lowest relapse rate ever recorded anywhere. Whereas the number of people who return to work or study and get completely back to their original lives is about 1/10 of that in other places. So it was shocking to see, but it wasn't randomized, right? So, the academic community, policymakers, guidelines writers wouldn't accept it until a randomized trial happens, which is why we're now doing that in the Odysseus study. In terms of what the principles, in response to your question, Chris, involve, this is a list of core principles. And as we go down this list, the further we go down the list, the further away we get from how we do things at the moment. The first thing is provision of immediate help. So we have that in our services, right? In crisis teams, you can respond to people within 24 hours if there's in crisis. That's fine. But the next thing is that we have an immediate social network perspective. So straight away, the clinicians are taught to start to mine the patient for information about other people in their lives. Who else is important to you in your life? Friends, family, neighbors, colleagues. Who else do you think could help? And we really spent some time trying to think that through to try and bring other people in, if possible. If not, we can still do it. The other thing is continuity of care is fundamental. So when we form that first network together, we need that continuity across the care pathway so that we're consistently having those network meetings following the spine. So, when I've done network meetings for patients, I've started to see them in the community. I continued to see them when they're in the crisis team, continue to do those network meetings in the inpatient ward as well. We invite the inpatient consultant into them, and we'll work collaboratively together. But the network meeting is like a forum, a public forum where things are then happening. Dialogism is like the secret sauce, if you like, to open dialogue. It's the therapeutic modality involved in the actual treatment in the network meetings itself. It's the answer to the question, what do you do in the network meetings? Well, the clinicians are actually trained to try to make sure that every voice is heard, so that all the different voices get a voice. And that's not easy to do, right? We very quickly try to forge a consensus or even have our voice to sort of dominate things. So actually being able to bring out different voices, we learn specific techniques about how we bring out different voices. And even within the same person, if they have different perspectives, we want to bring those out too. And so there's real training involved in this. It's about 4 weeks worth of intensive residential training that people have over the space of a year. So it's sort of spread out so it doesn't affect their work too much. And we do, for example, we do things like reflections where, you might have a couple of clinicians in the CPA meeting, the medic and nurse, who will reflect together with themselves in front of the network and talk about what they're experiencing. They'll talk about their subjective feelings around what's happening as well, really in an open way. And then they'll put it back to the network and say, what do you think about what we've said? So, rather than having meetings outside, we'll have it inside and in front of them. And in order to do that, we need to be able to tolerate uncertainty. So we need the clinicians not to jump in there with some answers straight away and say, right, this is what's going on. This is what we need to do. The sooner you do that, the less space you allow for dialogue. So we try to hold back on our interpretation of what's happening as long as possible in order to allow dialogue to happen. And it's not boundaryless. If there's risks to anybody, then we need to act on those risks in the same way we would anywhere else. So I've used the Mental Health Act, I've sectioned people in open dialogue. We've used safeguarding. You can do all those things you need to do if there's imminent risk, but usually there isn't, right? So usually we have that space in which we can tolerate some more uncertainty, create that space for dialogue, and try to give them the sense of being in charge as much as possible, giving that that control as much as possible. And main part of the skill is actually being present. Hence my overlap with mindfulness. We teach clinicians during the training about mindfulness and about the importance of being able to just be in the moment and following patients from one moment to the next, and really understand where they are. So you're connecting to their utterances rather than to some pre-planned map that we might have in our head. Another key aspect of it is flexibility and mobility. If you successfully manage to enable the network to take as much charge as possible, that means that they have a large say in what happens in the network meetings. So they might, for example, come up and say, you know what, and as it happened to be, a really important person who I'd like guidance from is my priest or a spiritual guide or leader. And we've been open to that, right? So then a priest to join the meeting, or somebody who's important to them in their life to join the meeting. And that's really helped, right? Then we can have an equal dialogue about where we can go with this. Also, suggestions for psychology or other kinds of input medication will usually, more often than not, it'll come from the network, right? We facilitate the dialogue and the initiation of it has come from the network. Therefore, the adherence in the long run is a lot better because they're coming up with it. But what this means is it's a very pragmatic model. There's nothing's forbidden. As long as it's going to be functional and effective and useful and agreed for the patient. But nothing is written off, and it gives us the space in which they can own it. They can start to think through themselves what their treatment plan is, and it's a lot more flexible because there are many more permutations if the initiator of the treatment plan is not so much the clinician but the network. So therefore, the permutations are a lot larger. So a very flexible, pragmatic way of working. In the UK, we copied actually the US. So the US imported open dialogue in downtown Manhattan when Obamacare came about in 2012. They invested $50 million into an open dialogue service called Parachute. And there they had peer workers in every single team who were fundamental to every team and the way it worked, which we did the same. We had peer workers involved in all of our teams. And those peer workers can help cultivate a community around the patient, help to develop a network, but also help to keep the team grounded. What we're talking about is understanding the value of lived experience, really giving a voice to lived experience. And so to walk the walk, we also should have lived experience in our own teams. So we have lived experience practitioners, peer workers in each of our teams. So we call it peer-supported open dialogue pod. And this is a slide from before, which I mentioned. Obviously, this is the whole trial starting in 2014. So that is, and as I said, some of the outcomes that we've already started to notice. So I'll just stop sharing there. So that hopefully that gives you a bit of a better idea of what open dialogue actually entails. Yeah.
Hmm.
That was really helpful. Thank you.
Yeah. No worries.
So can I follow up on that, Russell? Because I'm very interested in the decision-making process that has to
Yeah.
happen within these peer group, within these
Network meetings.
network meetings.
Yeah.
I guess it sounds as though it's extremely patient stroke service user focused, doesn't it? And that they have an authority within the group, which is central. But as we all know, our work is riddled with different sorts of tensions and conflicts, as you say, and the actual care process isn't there to establish a consensus. And yet, I guess you have to navigate towards decision making.
Yeah.
So I'm
Yeah.
just sort of interested in how that happens, really.
Yeah.
Do you find, is it through a sort of persuasion, or is it through education, or is it through what? And how do you manage people whose view of their mental health issues is just so idiosyncratically different to those around them that there is no hope of getting joint decision making?
Yeah. So good question. So we can think about this on a spectrum, really. That on the one hand, in terms of just having dialogue with people and reaching a decision generally, when you're not trying to impose one, we try to allow a decision to evolve from a dialogue amongst the network members, right? And we're not asking them to agree with each other. In fact, we're specifically probing them on what's different. What do you think about what so and so said? Trying to get there. We're not actually asking them to disagree with each other, but we're allowing the space for that to happen. And over time, the sort of consensus will evolve for people. We don't start that way. We're going to start getting everyone's different perspective, but it will tend to emerge. There'll be consensus that tends to emerge. Now, that's what happens at one end of the spectrum, and actually most of the time, because there is an imminent risk happening. So you can enable that to happen. It takes a bit more time to do that, but we can use that time, because what we found is that when we have these in a crisis, you have network meetings like this. You have one network meeting in a week, and you ask them if they want to wait a week for another one of these, or have someone visit them every day, and they'll say, "I'll wait a week. Actually, this is really helpful." So you've saved 5 meetings by having one instead. So that's in an ideal scenario, which is actually most of the time we're able to do that. But then you can have scenarios like the one you described, which do happen, all the time. All services will have this, where you've got either some risk or some sort of lack of cooperation, or desire to be involved in treatment or anything like that. And the important thing is, what we train folks to do is to really listen and be open to that, and to hear that perspective. And you can hear these things, and you. So for example, I'll give you an example. I was in a network meeting, and it was a young woman who'd taken an overdose and was a very serious overdose just days ago. And in the network meeting, she was talking about, she didn't have any regret about it. She didn't say anything about wanting to do something different in future, or wishing she hadn't done it. And so what you then do is that we then have a reflection amongst ourselves as clinicians in front of them, and we say, if you don't mind, my colleague and I will have a chat. Let us know what you think. And then we say, and in that circumstance, the nurse turned to me and said, "Look, I don't feel safe just sending them home and ending the meeting like this. It worries me, and I'm a bit worried about the risk to her here." So now this is a conversation we might have had outside the room, but we had it in there in front of them. We then turned to them and said, "What do you think about what we said?" And immediately different family members start speaking. "Well, you know what? She could stay with me for one night, and maybe I can be with her tomorrow, and until we meet you again next week, right?" So if we have genuine concerns like you described because of what's happening, and we know that it needs to go in a different way to what the patient is asking for, then we openly say that to each other in front of them, and then we give them the opportunity still to try to forge that plan together themselves. And in worst case scenarios, if that still isn't happening, then we might talk openly about how, and I've been in this situation, how the risk is such that, and I'd say this to my colleague, that this is not what I would ever want to do in this scenario. I very much regret we've got to this, but I think we have to think about the Mental Health Act here because of safety reasons. And if it's safe to do that, obviously if you're in imminent danger, you have to leave the room. But usually, I've been able to say that. And then we have deployed the Mental Health Act. So we can go all the way across the spectrum, but we're doing it slightly differently because we're being reflective, because we're giving them a space. And what I found, even when I've sectioned people, you then have a network meeting in hospital, and the relationship is fine. It takes us straight from where, because you've been really open with them and honest, and it hasn't been like the voice of God coming in to declare what should happen. And then that relationship is maintained, even though we've had to get fairly draconian. So that the real skill in open dialogue is not just about being open and allowing conversations to evolve, but also knowing when to switch to the other gear of being directive, but doing it in a way that gives them as much say as possible, so you can still maintain the relationship. So yeah, it takes a lot of practice. You know, I've been doing it for years. I'm still learning, and other colleagues can too. But yeah, the scenarios you describe are very much, you know, things that we're, you know, you know, we've got ways of trying to work with that whenever that happens.
I wonder if that's, sorry, I don't want to hog this, but I just wonder if that follows. I was just thinking about supervision now and thinking about the needs of the caring community
Yeah.
to have a reflective space to think about where they are. And maybe part of that caring community is the professionals, but not the entirety, isn't it? But the professionals, presumably, they might have some theory that they can bring, or theories that they can bring to their understanding of mental health problems, which is and they may also need some sort of supervisory forum to help them think. I hear what you say about the actual therapeutic intervention, if you like, is to have that openness, and so the minds of the professionals are open to the are laid bare for the benefit of the service user. But also there must be a space where you have to have conversations between yourselves with an external person, perhaps, because supervision. I come from a medical psychotherapy background, and of course it's integral to what we do.
Yeah,
but
absolutely.
in general psychiatry, it's you only have supervision if there's something wrong with you.
Yes, yes.
And that
Absolutely.
is such a foolish position.
Yeah, 100%. Yeah. So I agree absolutely with what you're saying here and where you're going with this, because, you know, a big part in my presidential campaign, I'm not saying we should all do open dialogue or anything like that. I'm just saying some of these things are really important that we should do. One of them is exactly what you're describing, some kind of, you know, it's also a form of personal development, right? To have that. So, you know, psychotherapists will have their own therapy, right? And yet folks who work in acute services, in crisis teams, will have nothing, right? And they're dealing with so much emotional turmoil. And where does that all go? You know, sometimes rebounds back to the patient. So what can we do to work on ourselves? So in open dialogue, it's one example of how we do it. The team meetings all have a reflective space in which clinicians are asked to come together to reflect about a network they're both in and share their subjective experience, just how they're feeling about it. Often it'll be about how much they're feeling stuck, right? Or maybe how afraid they felt, you know, or how worried they are. You know? So we have that reflective space in every team meeting where clinicians come together, share their subjective experiences, and then they turn to the rest of the team. Then the team reflects on their reflection, a bit like we do in a dialogue meeting. So we replicate some of that dialogical space within our team meeting. Every single week we have that. And then what we also do is that we have once a month, we have a sort of self-work session in the team where we pair them up, and they might do genograms together or family of origin or some kind of work in which they're working on themselves. And a big part of my presidential campaign is very much that personal development should become a part of professional development. You know, in fact, I think all consultants should have one of the supportive PAs that we have should be for personal development, whether that's for some therapeutic engagement, for mindfulness, or something that helps build your resilience. Because it's crazy to think that, you know, counselors will have their own personal development, and yet psychiatrists working in absolutely the coalface, the most severe emotional turmoil anyone will ever see, and you get nothing for yourself. You know? It makes no sense at all. So that, you know, it's one thing that the college can do, you know, really bring that to bear through our peer groups and things like this. So that will be fundamental. But you're absolutely right. That's crucial in an open dialogue setting. That's absolutely crucial. That's why the fidelity to open dialogue is not just about how the meeting is organized. It's how the care pathway is organized. It's also how the team meets itself, you know, and how they have their discussions.
Right. So, yeah. Ian, got your hand up again.
Yeah, sorry to jump back in again, but I'm kind of fast. I can't remember the lady's name, and you'll probably know it, Russell. But there's this movement within the College of Psychiatry saying, when we get suicides, it's not necessarily our fault. You can't prevent suicide, perhaps, and we need to push back against the blame culture. But and I kind of struggle with that, because how do we recognize good psychiatric practice and maintain it? I think we know bad psychiatric practice when we see it, and we probably saw it in that Manchester unit, the forensic unit, the Panorama program highlighted. And I may or may not have heard, probably be careful what I'm saying, and this is recorded, that the forensic psychiatrists were working from home. So maybe they weren't around in that unit to see the culture and what was going wrong there. But I think we are responsible for trying to be part of maintaining a positive culture, particularly in those kind of inpatient units. I remember going to a lecture by the famous Canadian-American psychiatrist Meyer Sims. First Meyer Sims symposium in the College of Physicians in Edinburgh, and the first thing Meyer Sims said was, "I've never had a suicide amongst my patients, inpatients, and I wouldn't hire a psychiatrist if I knew they had had a suicide in their patient group." And I was there with Sir Michael Bond, who was my professor at the time, and I think both of our jaws kind of hit the ground. But in a way, that's a challenge. I remember there was something more recent coming out of Chicago about, if you really work hard and you do certain things, you can bring your suicide rate right down. So that, what is it that we need to do to prove that we're doing it well? And, and how do you measure that? And I kind of worry about that movement within the college being a kind of, we do our best and, bad things happen. And maybe it's nothing to do with us, because that's, we work in a dynamite factory and sometimes the thing blows up,
Yeah, I see what you're saying. I think it is about getting the balance right, isn't it? Because on the one hand, I do agree with you that to take it to the severe end and say there should never be any suicides anywhere and that we're responsible if it ever happens is actually dangerous, because there's like these zero suicide movements. I've always been uncomfortable about those. You could create zero suicide by sectioning everybody, right? By locking the entire population up in hospital. That's seriously not what we're trying to do, is it? So there's preventative measures, there's things you can do in the community to reduce suicide. That nothing to do with a psychiatrist's job, right? So there's lots of things you can do to reduce suicide rate, all great. But we shouldn't be responsible for, an endocrinologist won't be responsible for everyone dying of complications of diabetes, right, in their area. So that doesn't make sense. However, we do in our work, but I don't think that we've been very good at doing that up to now anyway. So if you look at some of these, these terrible examples in Panorama and these things we've seen, at the same time, a lot of these places have decent CQC ratings, right? So the regulator is actually signing them off as doing a reasonable job. And yet then you see these terrible scandals happen just because someone turned up with a hidden camera in their service. So the way that our services are being measured is actually inappropriate, because what happens is, when you think about us as professionals in our revalidation, we're being measured on how many CPD things have you been to, right? Which could be anything. This was invented for Shipman, by the way, and he would have done really well through the revalidation process, right? So, and then you think about what the CQC measures. They measure how often you filled up a form, right? How many boxes have you ticked? None of this is anything to do with good patient care. So no wonder you get a decent CQC rating, a terrible service. There are things that we should be doing, like, for example, there's a move towards patient-reported outcome measures, which can be a good thing if you use the right measures. But if you ask patients to describe how much did I feel heard by my service, how compassionate, how kind were the clinicians who looked after me, you're starting to get into the right track by asking patients to feedback on this kind of thing. And then looking at other things like relapse rates, right? How often are people coming back? If we have a service that's getting people out quickly and they think they're doing a great job because they've got a rapid turnover, is that really helping people in the long run, right? And these are longer term measures, but we need to start instituting them. So I think some of these longer term measures, looking at somebody's trajectory, will be important on a sort of meta system-wide basis. but on a more localized and individual basis, just patient-reported questionnaires, just them reporting their experience of how compassionate a service was, which you can do. I found some of these questionnaires that I definitely proposed to, you can create dashboards from these to see where the hotspots are in services and how good, and you're exactly right. If the compassion looks like it's waning in areas and the patient experience is poorer, the consultant has a major role in influencing that. The culture that we purvey is fundamental. Certainly in an inpatient ward, for example, the consultant and the ward manager or the head nurse, they're the two most important people to set the entire culture of the whole place. So yeah, we have a major role in that. Our role is as much about leadership as it is about direct therapeutic intervention. So I think really focusing on how we assess that in better ways is going to be key going forward. So I agree.
Thank you very much. Yeah, great answer.
Just following on from that, actually, Russell, I was just thinking whether or not in the open dialogue trial that you've had, whether you've had suicides in that, and whether you'd continue with the network meeting if the individual at the center of it did commit suicide, and whether that actually might be quite a good thing actually for a difficult thing, but something which would help to move the process on, the grief. I don't know, but I don't know if it's happened yet, but presumably it will happen.
So good question. I'm not aware of any suicides within the open dialogue teams so far, but I think there may have been some in treatment as usual, but I don't know. I don't know all of the control groups. However, I had something similar, and I've had a patient death. He died of physical health complications, but he did die. And we actually did exactly what you said. We carried on the network meeting with his mother, and sometimes a nephew who came to the network meeting, and it was really helpful for them. And we really felt for him. We'd been working with this guy for years, right? And it was a tragedy for all of us. And he wasn't particularly old. I think he was in his 50s at the most, right? And he died very suddenly of a PE, actually. So it was so sudden, and the mother was so bereft. And it was really helpful to all of them for us to continue those network meetings. And we did several of them. We got to a point where we thought we probably aren't going to be able to continue much more. We were open with them, but we did have several, and it really did help. And it helped us as much as them, actually. It was very therapeutic for us too, to be reminiscent and be reflective in that way. So yeah, and I could see how in the suicide that would be even more the case. Yeah, very much. Yeah.
Can I? Sorry, does anybody else want to put their?
Yeah, there's just a hand up down there.
I think
Who's that?
Hi, I'm Chris. May I have a question, Russell?
Yes, go ahead.
Yeah, just I would like to just do what you did, or some colleague you talk on your last dialogue, means Trieste model implement in somehow my area. But my question is, how you manage to deal with the big number of patients? I'm responsible at the moment for 400 patients, and I cannot imagine, having a kind of meeting like this.
Yeah, so good question. I mean, the frequency of the meeting depends on the acuity, severity of the patient, right? So when somebody, we do it in combination with the community team and the crisis team comes together, right? So we train folks in the crisis team and us. So we tended to see people when they're in crisis, when they need maximum input, and that's when we do it. So, in crisis teams, people will have daily visits, yeah? So instead of the daily visits, we'll combine all that time and have one longer meeting, in the week. And we'll offer them daily visits, but 9 out of 10 times they'll say they don't want it. They would just like these kind of meetings. So you can really do it when there's a need for higher input, when they're at the sort of more severe end of the scale, and then you'll have relatively frequent, maybe weekly or every couple of weeks, network meetings. And then what happens is they get better, that reduces. And I've got plenty of patients who have one meeting a year, one network meeting a year.
Okay.
And everything in between is just the same. So they'll still have their medical review, they'll still have their care coordinator visit them, they might see a therapist, go to a group. All of that is just the same. But the network meeting frequency will go down as the crisis wanes. And some people have said, we don't need any more of these right now. We'll let you know when we need another one. And 4 years later, they've asked for another one, or sometimes they haven't at all. So we calibrate it depending on the need. And usually when the need is high, the input is high anyway. So we're doing it at a time when we're using a lot of resource. We've got a health economist who's part of the trial, and he's measuring the extent to which service is used over the 2-year period. Does open dialogue cost the same or less? For me, that's a really important finding. There's no point showing that the outcomes are better, but the cost is double, right? They'll just end up on a shelf again, right? We want to show the outcome is better, but the cost overall is less because the service use is A, less because they relapse less, but B, less actually because the way you deliver it means that it's only at acute times when they use a lot of resource that we need these network meetings more. And that's the opportunity. Actually, people then use them. People really use them at those times. You wouldn't do it otherwise. It doesn't happen as frequently otherwise. If that, hopefully that answers a little bit of what you were asking.
Okay, thank you.
Thanks.
Oh, Chris. Oh, is that a?
Oh yeah, I've started clapping. I was
You started clapping as well.
Okay,
I was intending to raise my hand.
Looks like you're awake. Okay.
I'd just be interested to hear your experiences with patients that would, however you would want to phrase it, I suppose traditionally of a kind of borderline type personality.
Yeah.
Because I could maybe see pros and cons. One of the things that particularly comes to mind is the issue that can often happen is when services aren't coordinated, that there can often be splitting and differences in behavior towards different members of staff. And I imagine having that network style approach with everybody involved together in the same place would perhaps be quite helpful there. And also just the sense of being the kind of power differential changing and everyone kind of being on one playing field. And it'd be interesting to hear how those kind of patients find it.
Yeah, so good point. I mean, you've answered part of it in terms of it really helps when you have clinicians coming together. Sometimes we'll have 3 or 4 clinicians in the room, specifically in cases like that, where there's a risk of splitting. So we decide we're going to see them together as much as possible rather than separately. And so that way, you can have that uniform view, or at least you overlap with each other so that, there might be a different couple seeing them, but it's actually overlapping. The other thing is that if you think about it this way, if we're able to go all the way to a mental health act assessment and section somebody in an open dialogue meeting, we can go halfway there and be very clear about boundaries as well. So there may be times when we have to say, actually, you know what, I'm not sure if this frequency of meeting is helping. Maybe we should dial it down, or maybe we should stick to the one-to-one, or maybe we should wait until the DBT is finished before So there's things like this that we can do. So it's not forbidden to impose boundaries, and that's why I say that it's easy when things are going well and you're just being dialogical and open and carry on and let it evolve. It's also relatively easy when you're just being pretty directive and saying, okay, this is what we need to do. But when you have to be in the middle and flip in and out of that, that's where the real skill comes. That's where it becomes difficult. But that's I feel that's our responsibility to try our best to navigate those difficult waters. And it isn't easy. We need to have those reflective spaces ourselves as clinicians. But we also need to be able to say, look, maybe we are offering too much space here for this person, which could be destructive for them, and having as much of those conversations as possible in front of them, so that they can hear that from us. So the difference is that we can try and have those thoughts in front of them. There's been a number of times when I've done that, like, how much are we helping here? I've literally said that, to my colleagues in front of the patients, and they've really appreciated that in the end. They might not agree with where we've got to in the end, but they appreciated the process.
David. David, have you got a question there?
Many thanks for that, Russell. I'm
Thanks.
not sure your approach is consistent with what what comes out of the college these days, but probably all the better for that, shall we say. Understandably, you were focusing on one of 2 pillars. Has your approach altered in any way the way that you and your colleagues would use drugs in conjunction with the work you're doing?
Yeah, so good question, David. It's a question that I do get asked fairly often, and I would say that it has reduced the amount of prescribing we do. Right, I can't give you a number on that. I don't know how much, but I know I prescribe less, and that is, we do prescribe, and there are plenty of times when it's needed. More often, though, we'll tend to prescribe when the network have asked for it. Right, so usually there's a conversation going on, and people have started to suggest, is there medication that can help? And then we've started to describe it. When that doesn't come up, then we don't go there unless there's a real need, right? So there's been times when someone's hearing voices and it's telling them to harm them, and I have to look, we actually need to start an antipsychotic. But I haven't said it to them, I've said it to my colleague, and I can't leave here without prescribing them. Right? But that's actually been relatively rare. Usually, if they haven't asked, then we haven't gone there. It's been about having the best idea for them is to meet again. That's usually been the best intervention. How about we have another one of these meetings? What do you think? And of course, the possibility of medication remains for future meetings. But when it has been prescribed, more often than not always, but more often than not, it's come from them. And therefore, actually, adherence to medication is a lot better as well, because it's been their idea. And we've tended to have a discussion between the professionals about what the options are, right? And then we ask them, what do you think about what we've said? So I might be discussing, with a nurse, comparing quetiapine to risperidone, etc., and what the differences are. And then I say to them, what do you think about this conversation? And then they might have a choice, So we're trying to give them as much control every step of the way. But that whole system then leads to prescribing happening less. I don't know how much less. It'll be a certain percentage, I think. It's one of the things we're going to measure in the trial and be able to publish data on at the end of it. But yeah. I do think, though, that adherence will probably improve, to be honest with you, when it is prescribed. Yeah.
Leonie.
Hello, and thank you again, Russell. I enjoyed, your presentation last time and this time, and I guess it makes absolute sense to me. And I think the voices of patients and relatives and family has been, more or less absent really in mental health, and that's what we need to be hearing. I guess my question is about our psychiatric community, really, and how open. I mean, I guess I'm asking you this particularly in terms of your candidates. Oh yeah, whatever. I can't say the word.
Candidacy, yeah.
Candidacy, yes. I don't know. Do you have a sense of how open our community will be? Because I guess you're speaking to the converted here. Maybe certainly I am, and there'll be lots of others. But I suppose in the technical, side of things, there will be colleagues who may be constitutionally not disposed to relational work. I'm putting it's pretty crude, really, what I'm saying in terms of.
Good question.
But I think because psychiatry, so much is dependent on the use of the self, isn't it? And how much we bring or don't bring to that relational field, really. I just wondered if you had a sense of how persuadable the community is, really.
Yeah, so good question. And I guess that my election campaign, my running for the position of president, is effectively a litmus test, a referendum on whether, to what extent do people buy this, right? To what extent does the profession of psychiatry in the UK want to work more relationally? That's fundamentally what this is about. And I'm very explicit about, that I want to bring about a more relational way of working, that we've lost something over the years. Psychiatry always had these two skill sets. Adrian, actually, current president, was telling me the other day, every single major psychological school of thought, way of working, intervention was developed by psychiatrists originally, right? And how ironic that we've almost disowned most of this. So psychiatry has lost something, and we need to bring it back. And that's fundamental to our profession. I also believe that if we don't bring it back, we'll eventually be replaced by algorithms. If it's just technicians, then all technicians are eventually going to be replaced. So, and actually, look at true psychiatry. Look at the younger generation now. I got to talk to ST trainees and others, and they absolutely lap this up. I mean, they're extremely excited because they came into psychiatry for two reasons. One is in medical school, they had a lot of training around therapeutic relationships, actually, and emotional intelligence. Medical schools converted over the last couple of decades, prizing that in terms of recruiting people and training them. And then they see the True Psychiatry campaign, which talks a lot about relational work. Actually, they come in and then they feel, well, where is sometimes they feel, why is this not happening? So they love this stuff. Younger trainees love this. If the election was amongst the young consultants and ST trainees, almost certainly win. But we'll see how it goes. And there's also a lot of colleagues who've been in the system a long time, like a lot of us, who have felt this way for a long time. I give these same talks I'm giving you. I've given this talk at least 50, 60 times across the country, right? There's always a population of colleagues who are electrified by it, actually. So this is what I've always thought. I've been waiting to hear this for years. Now, will they come out and vote? Do they feel strongly enough to do something about it? We'll see. You know, if it happens, then I'll win, and we'll know the answer to your question. If it doesn't, we'll still know the answer,
Okay.
which won't be as positive. So yeah, it's an experiment, really.
Yeah, I do agree though, that the trainees, in my experience as well, are definitely up for, and it's good to be in touch with them in the early part of their training.
Yeah.
Yes.
Yep.
Yeah.
Well,
No,
good
I have
luck.
a lot of hope. I mean, if I win, I'm very excited about the fact, you know, that the president has a major role in inaugurating all new members, right? And these days you have a ceremony and you give a talk to them and you go and meet them, and I'll be very excited about that, to, you know, about really giving them that sense of hope that we can move in this direction. And I actually think this time of crisis, where you have these scandals coming up, is an opportunity for us to really say, look, we need to have a deeper level rethink. We can't just do simple things, create more forms which would make it worse, which is the tendency amongst administrators, but really change the culture of our services. And I think we have an opportunity here. So yeah, let's see what happens.
Good luck.
Yeah.
I think David's about to ring the bell for time up, but I'm intrigued, Russell. The other two candidates and yourself will be at the Philosophy Special Interest Group conference on biopsychosocial models on the 13th of December. And I think the voting starts the day after. But was that coincidence? Or
it was, yeah. It was because
you're all participating in that day.
Oh no, us being there together is no coincidence, but the date of it is coincidence, because it was originally supposed to be like a month or two ago, and it was cancelled.
The Queen died.
That's right. It was after the Queen's death. Yeah. So then it had to be pushed back. So the date is a coincidence. And actually, I was just going to tell, and what they had the idea that let's get all the candidates in to chair different sessions. It was their idea to do that. And this is happening around the country. So I'm going next Friday. I'm going to the Southeastern Region annual conference, and each of us has given a speaking slot. So there are things like this that are happening all over the place, and it's good. I mean, we're getting exposure to as many colleagues as possible.
I think that's great. Yeah, it's democracy in action.
Yeah, exactly.
Look forward to seeing you in person in London.
Yes, you'll be there. Great, excellent. Look forward to seeing you.
Yeah. Because you're a busy man, Russell, and but on something of a mission, which I think is an excellent mission. So I'll be there, putting my cross against your name, I think.
Thank you.
But just one little point, I can't resist it, and it might just end up hanging there. But it follows on from Leonie's point about what would strengthen the persuasion bit, and I wonder if it's about. You started your talk tonight with a picture of Jasper's book, and Chris, who's on the call with me and us tonight, and I were both doing this master's in philosophy and mental health together, and one of the things that's come up there for me is whether or not there is a relational model of psychopathology. Not that we all know that psychopathology affects relationships, but whether or not there is actually a relational way of thinking of psychopathology. And then that actually might help to persuade people, because a go-to place there might, and this might be Leonie's, because Leonie and I are both cat therapists, a way of describing how we get caught up in one another's minds. And relationships, but there's other psychological therapies, including systemic therapy, of course, which might offer something like that. But it might need to sort of be developed, I think, a bit further to help people to think about the other parts of the psychopathological world, about how we conceptualize psychopathology from a relational point of view.
Yeah.
So we're going to be out of time, aren't we? So sorry about this, Russell, because maybe I'll just get off my soapbox, because I think I did an essay on this, and but maybe it will get picked up in the philosophy special interest group.
Yeah, no, I think it's very interesting, and I think anything that brings us into it, that makes us think about our own role and the dynamic and the influence of the dynamic on what we're seeing and what happens, is key, really. I think to put it all into objective space and not think about our own subjective space in that, it is never helpful. It can actually lead to some of the sometimes uncompassionate stuff that we see. So yeah, I think very much the more self-awareness we can build, whether it's as part of our, understanding of what's happening, or just, personal support and well-being, the better I think our services will be ultimately. So I think there's a lot of mileage in that direction of travel for sure.
Yeah. So thank you very, very much indeed for coming back, and best of luck with the remaining part of your campaign. And let it, carry on beyond whatever happens.
Yeah, absolutely. Thanks very much. We've got just over 100 months left. Voting starts on 14th of December, but you'll all get your emails soon. Yeah. Thanks very much. Lovely to meet you all.
Thank you.
Great to have a
Thank
chat.
you.
Thanks very much.